Hello, everyone, and welcome to the Henry Schein webinar series on COVID-19. I'm Dr. Gary Severance. And as usual, we'll start off with Dr. David Reznik and his clinical update, but we'll follow that with some information provided by the ADA's Health Policy Institute, who's been polling offices throughout this entire pandemic. And we get to share some promising information based on their latest poll. But first, Dr. Reznik.
Thank you, Gary, as always, and it's always a pleasure to share the newest information and keep everybody as up-to-date as possible with where we are with COVID-19 and dentistry. And this time we're going to sort of take a little bit of a different path and see where we are with addressing the disease itself. We've done a lot of work on infection control, a lot of work on the ADA guidelines, the CDC guidelines, the interim guidelines for returning to practice, dealing with our states. And I know that we're all still going through quite a bit. In my own practice at our hospital, we're at about 50% of our normal patient volume. And I know that many of you are slowly reopening. One of the things that we are doing here is I'm not really doing a lot of aerosol generating procedures at this point, is making or requiring my staff and myself when I'm on the floor to wear our N95s, our full garb, so we're practicing our doffing and donning before we enter to the aerosol generating procedures. I want to have this down as much as possible so that my staff and my patients stay as healthy as possible. So with that, let's talk about some of the newest data from the Health Policy Institute from the American Dental Association. 90% of dental practices are open for elective care, and that includes mine. We're doing a lot of removable right now. We had a lot of cases that have been sitting for some time, so we're trying to deliver, do try-ins, do impressions. We're really making some progress there. We have about 2 states that aren't open for elective procedures, and that will probably change as we move forward. Patient volume is rebounded, which is great news, but we're still at about 53% of where we were, but it's still better. 70% of dentists are saying their schedule is about half full, which again is another positive. We're also beginning to get a little bit more access into our N95s and KN95s, and there are fewer offices who are basically stating that they're not able to acquire the appropriate PPE and face shields and gowns. That's just a little bit of a basic overview. Dr. Severance is really going to cover this in much better detail after I'm done with my portion of today's webinar. I did want to talk a little bit about surveillance data that we're seeing, and some things that I thought were sort of interesting. If we look at hospitalizations, they're 6 times higher, and deaths are 12 times higher for COVID-19 patients who have some of the following conditions. And a lot of this caught me by surprise. Cardiovascular disease at 32% does make common sense. Diabetes at 30% makes common sense. I was surprised that chronic lung disease was only responsible for 18% of the hospitalizations or deaths. So it's a smaller number when you look at it, but literally cardiovascular disease, a history of that is something that we might want to take into consideration. If you're older and you have cardiovascular disease, maybe you might want to avoid crowds, that kind of thing. Parts of the U.S., this is not over, regretfully, and I say that most honestly. We are still in phase 1. We're not in the part of phase 1 that hit New York so hard, where if you turned on the news, you would hear the word ventilator 20 times in the first 5 minutes. So we're not quite there, but we really have never ended our epidemic. And what we're seeing are increased cases in the Sun Belt. And that's something that we need to focus on, because if you remember back to the very beginnings of this epidemic, we thought that when the weather warmed up, that we would see fewer cases. And as of now, as we're just approaching summer, that has not happened yet. We're still seeing increases in Florida, Texas, and Arizona. There are also increases in Alaska, Arkansas, California, North Carolina, Oklahoma, and South Carolina, having record numbers. So really, we're still seeing some states being battered by this disease. So as of last time when we talked, or as of last weekend, the coronavirus cases were still increasing in 18 to 20 states. So we're seeing them near record or level highs. This I really want to get across. This is not over. This will probably be the most confusing slide I will use in these webinars or possibly have ever used in my career. But it gives you an idea of where states are increasing, where you are, because your precautions and how you operate really depend a great deal on your local environment. If you have a very small number of cases that might be counties away, then your office might not be as concerned, but we still need to follow the guidelines. So that means follow the N95 for aerosol generating procedures. Don't use the ultrasonic scaler. So if you look at South Carolina, you can see it's red. Now, this is not red and blue politics. This is red meaning increasing in number of cases, blue showing a decrease in number of cases. So you can look at Delaware, where the cases are decreasing. You can look at Wyoming, which peaked up, but now is seeing a little bit of an increase in cases. Nevada seeing an increase. Washington, where they're basically nowhere near their peak and they're doing good. Idaho as well. So you can look at your state, see where you are with the epidemic, and you can see some places that are increasing and some places where the cases are decreasing. Again, it's up to you to watch the epidemic in your environment. Why are we seeing this increase in cases? Is it because we're doing more testing? Is it because of more hospital cases? And I think it's really important, again, just to look at science and base all of our discussions on evidence and try to keep it based in fact. So the increase in cases is really not just due to more testing. In some places, cases and hospitalizations are on the rise, even as testing rates go down. So that's something we need to pay attention to. In 6 states, the 7-day average of new cases increased since May 31. So we're seeing increases in 6 states, while the average number of daily tests conducted has declined. Again, it's not necessarily more testing, but if you do more testing, you will identify more cases. So that is true, but it's not the only reason. In 14 other states, the rate of new cases is increasing faster than the increase in the average number of tests. So there's warning signs that the U.S. is seeing a resurgence. I don't want to call this phase 2 or the second round of this. That's going to be fall and winter. Right now, we're still dealing with the first phase of the pandemic. Something new that popped up that I thought was worth sharing is that there's some evidence that COVID-19 might trigger the onset of diabetes in otherwise healthy people. And we already have a huge issue with diabetes in many parts of our country and pre-diabetes in many parts of our country. So this is something to keep an eye on. There is a new global registry that's been established to collect data. And so we can track this on COVID-19 related diabetes. This was actually published in the New England Journal of Medicine. Mutations, something that is sort of interesting to talk about. Working in HIV for all these years, we've had to deal with mutations as medications would start, and then the virus would outsmart us and it would mutate. And this is the same thing that's happening with coronavirus. It's not related to medications. It's just there is a specific mutation, the D614G mutation, which significantly increases the ability of the virus to infect cells. Now, this came out from U.S. researchers out of the Scripps Institute in Florida. This research may explain why early outbreaks in some part of the world did not end up overwhelming health systems like it did in Italy, like it did in New York. So there are other places around the country, around the world, where you didn't see these overwhelming epidemics. And that's basically due that this mutation just makes it more likely that you're going to get the disease. The good, and what it does is it increases the number of spikes. So if you've seen multiple pictures of coronavirus, you see those spikes around the virus. This actually increases the number of spikes on the coronavirus, and that gives it its distinctive shape. And those spikes will allow the virus to bind and infect cells. So if you have more of the spikes, you're going to get more cells that are infected. So it's more contagious. This has actually become the dominant mutation that we're seeing around the world. And just to point out that the number or the density of spikes that we're seeing is actually 4 to 5 times greater. So it's more infectious. The good news is there is no evidence that this is more deadly or harmful. And I think that is very important. The study looked in a lab, so it's not necessarily in human beings, that viruses carrying that particular mutation infect more cells and are more resilient than those without it. So I'm putting a warning, and I'm going to start doing this on all of the slides, that all of the research that's related via press release. Before this pandemic, if you were going to publish something, you would go through a rigorous peer-reviewed process before you would speak to the public. But since this is a global pandemic, parts of that system have been bypassed, and a lot of people are releasing information by press release, which is unusual. So the study that I'm talking about is currently undergoing peer review and was released last week amid reports that the study was out there. So looking at what was going on with this mutation. I'm going to move on to something else that we're looking at, which is very important to all of us as we're looking to get back to a sense of normality, is where are we with a vaccine? So there is a coronavirus vaccine tracker. You can look at preclinical, and I know this is going to be a review for many of you, but it also, I'm going to add some information on where we are. So preclinical studies are where scientists or researchers, physicians, nurses give the vaccine to animals such as mice or monkeys to see if it produces an immune response, and there are a lot of candidates. There are 125 candidates in this preclinical phase. There's phase 1 trials where the researchers give the vaccine to a small number of people to test safety and dosage, of which dose works, what safety issues are showing up, and we've been doing that in HIV work for years, and does it actually stimulate our immune response? Right now we have 8 candidates in phase 1, so we're making progress there. In phase 2, scientists give the vaccine to hundreds of people split into different groups, and I give the example of age to see if the vaccine acts differently amongst the different groups. They also test the vaccine's efficacy and safety and ability to stimulate an immune response. And we have 8 candidates that are already in phase 2 trials. So very fast progress. I honestly, working in HIV where we went from a death sentence into a chronic disease, and that did take a couple decades, watch it, and it was remarkable on how fast that happened. Looking at where we are with coronavirus is really, truly remarkable on how fast we're getting to where we are. A phase 3 trial is where researchers give the vaccine to thousands of people. Many of these trials are what we call double-blinded, where one group will receive the vaccine, the other group will receive a placebo. And the goal is to determine if the vaccine will protect us against COVID-19. And we have 2 candidates that are entering into research in July. So that is right around the corner. So we're getting closer to see what kind of response we're going to get. Then we go to the final step, which is approval, where regulators will review the trial results and decide whether to review a vaccine candidate. Now, we always need to be safe when we're doing vaccines, and so they're really looking at the safety data and the efficacy data. Are we actually getting the immune response that we want? During a pandemic, however, a vaccine can get emergency use authorization before formal approval, and we've seen a lot of emergency use authorization being employed during this pandemic. There are different types of vaccines that we're looking at. There's genetic vaccines, where a vaccine uses one of the coronavirus's own genes to provoke an immune response. There are viral vector vaccines, where you give a virus to deliver the coronavirus genes into the cell and immune response. And both of those are actually being studied in HIV as well. There are protein-based vaccines, which use the coronavirus protein or protein fragment to elicit an immune response. Whole virus vaccines, where you have a weakened or inactivated version of the coronavirus to provoke an immune response, and then repurposed vaccines. And so what I'd like to say is there are literally trials going on or preclinical on all of these different types of vaccines, whether it's genetic or viral, which we'll talk a little bit more because we do have candidates in those that are moving faster, or whether it's a repurposed vaccine, which we have one that's in study. So we are actually looking at all of these different vaccines, and it's a remarkable effort. We have something called a warp speed program in the United States. The Operation Warp Speed has selected 5 of these vaccine projects, and they're receiving a great deal of funding to support that there's proof of the vaccines will work and that they're safe. The 5 companies that were selected by the U.S. government include Moderna. Many of you might be familiar with this company because in May they released data on 8 patients and it received a lot of press, a great deal of press. It's an mRNA vaccine or a genetic vaccine. There's Pfizer, who's working with a German company, BioNTech, and a Chinese firm, Fosun Pharma, to develop another mRNA vaccine, again, a genetic vaccine. And then you have Oxford University and AstraZeneca. They've teamed up together looking at a viral vaccine candidate. J&J looking at a viral vaccine candidate, and Merck also looking at a viral vaccine candidate. So you have 5 companies very experienced in working with infectious diseases, teaming up together, trying to come up with a candidate that will enable a vaccine to be identified so that it's safe and show that it's effective. All 5 companies are going to have access to a lot of governmental money and support in running these trials with financial and logistical support. And the key is, if we find one of these that is working, we need to be able to produce it rather quickly. And so a lot of the effort is also going into that. I'm going to read something from Dr. Fauci's interview. I have worked with Dr. Fauci when I was on the Presidential Advisory Council for HIV and AIDS. He is a man of remarkable integrity, and he is remarkably bright. And so what I will say is I'm just going to read this to you. I'm cautiously optimistic that with multiple candidates we have with different platforms, which we just discussed, we're going to have a vaccine that shows the degree of efficacy that would make it deployable. The reason I think so is that one makes a pretty good immune response against the coronavirus. Even though the deaths are profound for this outbreak, the majority of people make an immune response which clears the virus. So that's good news. That's my addition. If the body is capable of making an immune response to clear the virus in natural infection, that's a pretty good proof of concept to say that you're going to make an immune response to the vaccine. It's common sense. However, having said that, there's never a guarantee ever that you're going to get an effective vaccine. I'm concerned a little bit more about the durability of response, and that is key. That's why I've highlighted here, than I am about whether you're going to get a proactive or protective response. Because if you look at the duration of protection, when you recover from one of the several benign coronaviruses that causes the common cold, the durability of protection is only measured in a year or less, as opposed to some of the other infections where you could have a 10 to 15 to 20 year degree of protection. So that is one of the key components here, is how long will you be able to have protection from a vaccine? Is it something that you're going to get annually, like a flu shot? Is it something that you're going to get once, like measles, mumps, and rubella? I mean, there's difference on how this is going to work. And so we're still in that part of the phase. On a medication update, some interesting news from the FDA. They did revoke the emergency authorization to use hydroxychloroquine and chloroquine for the treatment of COVID-19. Basically, numerous studies said that it's no longer reasonable to believe it's going to be effective. However, at the same time, the AIDS clinical trial group has recently started a trial looking at hydroxychloroquine and azithromycin for mild to moderate COVID-related disease. So it still is being employed as a component in some studies. You might have woken up this week in the morning and seen that there was a big news that scientists hailed dexamethasone as a major breakthrough in treating COVID-19. Again, here is a warning. This research study is currently undergoing peer review and was released amid reports of its findings. So again, science by press release, but there is a lot of science to back this. So the results of the recovery trial, and I'll go into a little bit more detail on the recovery trial, were announced on June 16th, showed that dexamethasone, which is used to reduce inflammation in other diseases, reduced death rates about 1/3 amongst the most severely ill COVID-19 patients admitted to hospital. Now that is on positive predictive value and things of that sort. So I've broken it down into a little bit of a different way of talking about it, and I'll get there in a moment. One of the authors of the study actually said it's going to be very hard for any drug to really replace this, given that for less than, this is a UK study, 50 pounds or our equivalent of $63, you can treat 8 patients and save a life. So what are the numbers? Is the issue with this study? The recovery trial compared outcomes of around 2,100 patients who are randomly assigned to receive the steroid, with those around 4,300 patients who did not get it. So the results suggested that 1 death would be prevented by treatment with dexamethasone, and this is low-dose dexamethasone, among every 8 ventilated patients. So we're talking very seriously ill patients. 1 death would be prevented amongst every 25 COVID-19 patients that receive the drug and are on oxygen. So again, these are patients who are severely ill and did better with adding dexamethasone. Among patients with COVID-19 who did not require respiratory support, there was no benefit from treatment with dexamethasone. It's sort of an interesting argument using dexamethasone. I've actually used a liquid formulation of this for years to treat some aphthous ulcers. I use it more as a topical than a systemic therapy. And so some of my colleagues are worried because if you have a viral infection and you add a steroid, or a bacterial infection, you add a steroid, you can make it worse. But these are severely ill patients who are doing better when you give this medication to them. And so I think the key here is it's a component of what we'll most likely will see as a combination therapy. As other aspects of therapy come along that can actually address the virus itself, if you're very ill and you're in a hospital and you're on a ventilator and you have no options, adding a small amount of dexamethasone is not going to break the bank, but save a life. And I think that is actually wonderful news. Some other news is that NIH has launched a platform to harness nationwide COVID-19 patient data to speed treatments. And this is really important news. This National COVID Cohort Collaborative, or N3C, which is a lot easier to say, will help scientists analyze a lot of data that's coming around from medical records from people diagnosed with coronavirus from around the country. And it's to help understand the disease as well as to create some treatments. This project is funded by the National Center for Advancing Translational Science, and that always gets me excited because you're getting bench work and research, and you're actually taking it to the clinics and to the patients and showing how this connection works. So it will create an analytical platform to systematically collect clinical, laboratory, and diagnostic data from healthcare providers and organizations nationwide. This is a remarkable effort to get the data and to see where we are and to collate the data and get better outcomes for those we serve. It will harmonize the aggregated information into a standard format. So we will have apples versus apples, not apples versus oranges, which is also important. There are about 35 collaborating sites across the country, and the platform has diverse data from individuals tested. And you can look at things, just to think, can we predict who might need dialysis because of kidney failure? Who might need to be on a ventilator because of lung failure? Are there different patient responses to coronavirus infection that require distinct therapies? You can get all of this information and collate it together, have a remarkable database to help the people of the United States, North America, and the world. It's very exciting to me. It's the harmonization of data, which is really what is important, where hospitals do store data on different formats that we can get contributing sites to add demographics, symptoms, medications, lab test results, and outcome data regularly over a 5-year period of time, enabling both the immediate and long-term study of the impact of COVID-19 on health outcomes. I'm very excited about this whenever you can get all the information together and people working in harmony to find a result, and with a sense of urgency, which we all have, the outcomes are going to be improved. With all that having been said, everybody in the dental field and people outside the dental field have been going through a great deal of stress. And we need to understand that we're going through a lot of stress. We're having new systems put in place. We've financially been hit. Our practices aren't what they were. We might be out of a job. I have residents, fabulous residents this year who are not able to take the boards right now and will be unemployed after spending 4 years in college trying to get into dental school, managing 4 years in dental school, and now they're going to be unemployed and there's nothing I can do. I'm helpless to help them. And so try to figure out ways to reduce your stress and those around you and recognize that there is stress. So know some of the common signs of stress. Talk with family and friends by phone, text, or email. Take a break from news. Dear Lord, I listen to local news now so I can figure out what the traffic and weather is. Take a break from social media and do some healthy habits, because one of the risk factors for bad outcomes for COVID-19 is obesity. So if we can just exercise to reduce some stress, we can find things that we enjoy. I like flowers, whatever it is that makes you happy. Take a break from the stressful world that we're in. Think positive, because we are making progress. We are going to make it through this as a team. Thank you again for your time and your attention. And with that being said, I'd like to turn over the rest of our webinar to Dr. Severance. Thank you.
Thank you, Dr. Reznik, for the clinical update. And yes, there's some encouraging news coming out of the ADA's Health Policy Institute. They've been polling offices since the pandemic began. And as you know, some states have been now open for over 5 weeks. Their June 1st poll shows some encouraging results and gives you a sense of what our profession is really going through. So I'd like to share some of those slides and information with you, but also encourage you to attend their weekly webinars and find out more. So first, this is where you can find them, ada.org/HPI. You can find the recordings of the webinars, you can get the slides that they use for this one in particular, and really it's a wealth of information. On June 11th, this is what they presented. It's basically the dental care rebound, and some promising news here. How far have we gotten and how far will we go? And what they had was a panel discussion. And Marco is the moderator and normally goes through this in depth, all this data in depth. I love listening to him, such a brain and such a focus on what's best for dentistry and how can we make it better. So really appreciate what he does. And certainly all the panel members were excellent and provided their view on it. So it's worth a listen and worth listening to every week. Also, Marco's one of the only people I hear or listen to that uses the term data correctly. As we know, data is a plural. So he keeps saying these data represent, and I keep thinking it should be this data, but he's always right. So on to some of the slides and some of the places I've utilized their data just to make it a visual for you. But they started off by looking at how other industries or the economy is rebounding by measuring some things. Here, U.S. home purchases are above baseline and certainly above where they were in March. So in addition, they give some insight to all of this data and to make kind of a cliff notes. The public is slowly starting to get back to usual activities. And then they looked at even some more unusual ones like open table, which means people are making restaurant bookings. And that's starting to come up, certainly nowhere near as fast as others, but they're slowly starting to get back to the usual activities. And then one that fascinated me was looking at Apple Maps. How often are people looking for directions, whether driving, walking, or public transportation? And you can see this is only U.S. Information. But I went to the site itself, and you can do this too. Just type in mobility trends reports on Apple. And you can type in the United States and see it there. You know, rapid transit where you can't keep social distancing is still down, but driving and walking is near above baseline. If you look at Canada, similar rotations there. And you can type in states. So I typed in New York City to show that they haven't reached baseline, certainly on walking and or driving. Dallas, we've been essentially in phase 1, 2, and 3 now for the last 5 weeks. So we're back to normal and above baseline. But you can do your own community too. And that gives you an idea of how out and about I think your patient base would be. And then they did look at patient volume. And we know states, 90% of them are open now. About 1/3 of large dental practices, meaning 10 plus, are seeing 3/4 or more of their typical patient volume, according to the June 1st poll. And you can see the different categories: solo, 2 to 9, and 10 plus dentists. And so it's a good indication of that. But even better was Steve Thorne, who's the CEO and founder of the Pacific Dental Services, one of the largest DSOs, released this to the group. And it shows this sharp drop off on patient visits in March, early March, but then this slow climb. And already 8th of June, they've been, I think, about 72% now of baseline or near normal pre-COVID visits. And it was Steve that kind of used a very clever reference of it was an elevator ride down, but an escalator ride up. So it's gradual, but it makes very good sense. And I think that trend shows not only in the mortgage area and Apple and all of this, but also dental visits. And then each week they've talked about the availability or stocking of PPE. And so they interview or they poll, dentists participate, and you can go on and volunteer to participate on your questions. They have a question of the week. But this is very informative too. So they compared 3 weeks, week of May 4th, May 18th, and June 1st. And what we're trying to do is, if you look on the left, some aren't sure of what stock they have. You can look at, they have 0 days on week, or on the week 4, you can see the red was much higher than should be and much higher than the surplus. But in particular, to make a reference, greater than 7 days of stock is the green and the turquoise bar. So nearly 70% probably have more than a week's supply of KN95s or N95s. Surgical masks even higher, probably about 90% have more than a week's stock. Face shields, not necessarily as fast as the surgicals, but still quite in line, probably 80 to 90%. Gowns are the one that's lagging now, and we know that, or those that have acquired. So as you know, Henry Schein scouts the world and tries to keep inventory, and I think they're getting back to levels. So you should see on the next week even better stocking of this. But this is the interesting data that shows you're not alone in dentistry, and you can start to gauge what's going to happen. And then they reflected on, and this actually is a New York Times article that appeared, because we know dentistry took a real hard hit in the end of March and April on losing jobs, but they've gained now 250,000 jobs in May. So it's leading the rebound in the health industry. We led on the drop, but we're leading on the rebound. And they gained, the jobs that they did gain was 10% of the net jobs across American economy. So it made a big impact. And you can see it drop down to just under half of the workforce, but it's making its way back. So that's very good, as promising of bringing in team members back into the practice. And as you ask, what was very key is they segregated the 27 states that opened to elective care 5 weeks ago. So essentially, if you're in a state that only opened a couple of weeks ago, you can kind of give a predictive index of what's going to happen. So their insight here is in the 27 states that have been open for elective care at least 5 weeks, 98% of dental offices are open and 29 report business as usual. So majority of June 1st open, but lower patient volume. Second to that, open and business as usual. And you can go and see the slides where they actually give the numbers itself percentage-wise. And then asking the offices all the way from March 23rd to June 1st, are you fully paying your team members or staff? And in the 27 states that have been open for elective care for at least 5 weeks, dental offices are nearly back to full staffing for team members. So pretty incredible gauging that bounce. And also they included some consumer surveys where dentists has always gone up in trust and up in confidence of going back. And we continue to see this. Now, I added the heart arbitrarily. They want to see their primary, in this study, the primary doctor first and dentist second. Unfortunately, the mental health is last, where we probably all need it the most. So if you look at that, good information to have. Additional one also supported it. I added the heart, but dental or medical appointment in person, 82% in the next 3 months. I expect them to do that. And what's interesting here, it's higher than even eating at a restaurant, staying in a hotel or vacationing, flying in an airplane, attending a concert. So the activities they want most, it seems, are dental and medical appointments, which is all positive. And finally, another one, Fleischman-Hillard looked at which of the following are planning to do in the next 12 months, going to the dentist, number one. We're pretty much the only profession that, other than maybe medical, where you get a physical once a year. You know, the idea, the rule is go see the dentist twice a year, so this is good. Again, the heart's added arbitrarily just to show dentistry where we're going here. So it's pretty incredible when you look at not only the takeaways from this, and this is quoted from the summary slide, but in general it gives you a real barometer of dentistry, what's happening now. So as of the week of June 1st, 90% of dental offices in the U.S. were open. Patient volume had rebounded to 53% nationwide. In the 27 states that opened for 5 weeks now, 64%. Hiring back team members steadily as well. PPE is getting better. The past 2 weeks saw significant improvements in PPE availability, including N95 and KN95. And most dentists report their appointment schedule for the next month is at least half full. 8% it is completely full. And consumer attitudes, which were the last 3 slides, are very encouraging when it comes to visiting the dentist. The data indicates the public is prioritizing visiting the dentist when it comes to getting back to normal. One thing that should be said about all this, there was some caution among the panelists, that is, there pent-up demand, are people just looking to get out, so maybe it'll soften a little bit. And we all know in a marathon, the last mile is probably the toughest, but everybody, I think, on the panel provided input that was more promising than they expected. So the final summary, taken together, data for the week of June 1st continue to indicate a robust recovery in the dental economy so far. And again, you want to keep an eye on this. It changes, obviously. Everything does weekly. ada.org/HPI. It's a great service that take advantage of. Health Policy Institute. Watch the webinars, go there, get the slides, and be educated on dentistry and what's happening in dentistry as a profession. So as you can see, great information, and I hope you do attend their webinars or view the recording or see the slides themselves, and you can see them at the HPI's website. Now, if you have any information, questions, concerns, or ideas for future episodes, please email us at webinars@henryschein.com. And also please subscribe to our YouTube page to get the latest notifications. As always, until we see you again, certainly have a very happy Father's Day weekend, and stay safe and stay informed.